All right, so we're going to delve into PTSD overview. Maybe I should stop here and ask for questions just about brain injury, so we kind of can step back and talk about that. Any questions? Do you have some questions back there, Walt?
Not yet.
Not yet. Yeah.
With my job, we review medical records that have come from various places, and we can order a neuropsychological evaluation. But typically what I see is old injuries, and that they're telling me a story about their life and find out that there was a trauma or there was an injury.
Mm-hmm.
And when I do get records, sometimes it's not stated as a TBI.
Mm-hmm.
So when you see something that says like frontal lobe damage,
Mm-hmm.
or maybe there's one for multiple concussions, I forget what it's called. Would we be okay in just saying TBI too? I mean, if you're talking about their closed head injuries,
Mm-hmm.
Because I work for Office of Vocational Rehabilitation.
I was going to ask,
Yeah.
so I'm glad you
So we
clarified.
have to use certain criteria for categorization,
Mm-hmm.
and it would be either a neurological impairment or a TBI.
Right.
And so when it doesn't say TBI,
Mhm.
sometimes it's trying to split hairs. But what are your thoughts on that when they're using different terminology and still?
My thoughts is to go ahead and order that neuropsych, because they're going to delve in and ask the questions that need to be asked and look at the specific deficits and have the tests that can look at cognitive functioning. So then when you categorize them, they'll be able to give you that language and the language you need. So if there's a question on classifying, if it's not classified for you, that's what I would do. Does that answer your question at all?
Thank you.
Okay.
For the people online, could you maybe summarize the question? Because I'm not,
Okay.
to that microphone, I'm not sure they can hear it.
Okay. So the question was if the individual works with voc rehab and they're looking at how to classify those individuals for services, right? And they're looking through charts, but it's not clear on level of impairment or type of TBI. What would you do? Would you classify something that says frontal lobe damage?
Yeah, I had frontal lobe impairment the other day.
Frontal lobe impairment, or would you go ahead and order further testing? Okay. Did I sum that up good? Okay, cool. So what I recommended was to go ahead and do the neuropsych, because they're going to have the test and get the information or seek out information from a secondary source, a loved one if possible, a family member or something, or just have the test where they would be able to classify. So, nothing online?
Nothing online yet.
Perfect. Great. All right. So here we are in PTSD, and of course I've been trained as a clinical psychologist, so I know what PTSD is. It's just like, you know, any medical field doctors out there. It's kind of like when you're not going to go to a leg doctor for your heart, okay? So I don't treat trauma. Let me just say that in terms of PTSD. I don't do that work. I love that other people do that work, but it's not my field. I love brain injury, and I love working with my patients, and it works perfectly for me. But do I know what PTSD is? Absolutely. Am I going to be able to talk about it as well as Dr. Rudisell could? Probably not. And the reason I chose her in particular, and I'll give a shout out to her, is that she also worked in brain injury under me at the brain injury program that I ran here in town. And then she has went on to the VA, and she is working with PTSD and substance abuse. So she has that foundation. So she would be really good at looking at both of these together for us. But, you know, I'm going to give a stab at it, and we'll see how it goes. So I also want to say that, you know, when we're talking about trauma, it can provide triggers. So it's important for, if you need to take a break or leave, if it's triggering any of you, that is fine. Get up, go. you know, your well-being is most important, or if you just need to go to the bathroom because you've been sitting here for a while, do that too. So there's that. All right, when we look at PTSD, their U.S. lifetime prevalence rate is 8.7%. Of course, there's higher rates in veterans because veterans are being exposed to things more often. If you look at higher rates based on vocation, we have police officers, firefighters, emergency medical personnel. Those are being exposed, so there's an exposure factor there. There's higher rates of PTSD and types of trauma, so you're going to see more severe trauma when it comes to rape. So 55% of rape victims develop PTSD, whereas when you look at accident victims, it's 7.5%. So it depends on the type of trauma. And then you also have to keep in mind how people express their trauma is going to be different. Not everyone expresses trauma in the same way, just like not every brain injury is the same. You don't treat it the same. You treat the individual, not the diagnoses. So some people may present with sub-threshold presentations and then later in life meet full criteria for PTSD. So it's just that they're ready to kind of discuss that and nature of impairments. All right, so in terms of development and course of PTSD, age, it can occur anytime after the age of 1. Time of onset is usually between within the first 3 months after the trauma. However, there may be delays when it begins, and it could be years before someone meets full diagnostic criteria. We call delayed expression anything after 6 months. So, and then duration, symptoms can vary. I mean, sometimes people complete recovery within 3 months. But, you know, if you look at history and how mental health has grown and been destigmatized over the last, I mean, if you look at 50 years or longer, you know, we've improved on treatment, we've improved on recognizing, we've accepted the fact that people can talk about things. You also have to look at, when you compare Vietnam veterans to our current veterans, it's different. Vietnam veterans, they came back, didn't talk about it. 1, because stigmatized, and 2, there wasn't such a thing, and we're not going to talk about that. So now we're getting Vietnam veterans into the VA, and we have to like encourage them to talk about it. They have to build trust with you to talk about it, and it's very hard for them because they've been told not to. Newer folk, while it still is hard for them to talk about it, they're more open to discussing things. I think sometimes they're more concerned that what they're going to share is going to harm you. And so as a professional, we have to say, just tell your story. I'm trained for that. You know, it's okay. So there's definitely some barriers. So that's the reason we're seeing that sometimes people aren't coming in and it's still lasting for a long time. And I think, you know, as we grow in a field in terms of mental illness and we continue to get rid of that stigma associated with it, we're going to continue to see people kind of push themselves. You know, there's also a cultural piece to that. I'm from Appalachia area in Eastern Kentucky, if you haven't heard my accent already. So that in general, that population tends to be closed, and mental health there is stigmatized at times. I'm not saying everybody, I'm not generalizing by any means, but you know, that does cause problems. So, all right, so risk and prognostic factors. So before trauma happens, we already know that there's some risk factors for individuals. You have to look at temperament of an individual. anxiety problems, panic disorder, depression, if that's already present prior to the age of 6 and they're exposed to a trauma, it's likely going to lead to PTSD. Environmental factors. So, you know, what we're seeing is lower SES, lower education, and then exposure to trauma during childhood is a problem. And then just genetic and physiological things. I have to catch up with myself here. So we look at gender. We're most of the time female gender increases the likelihood of risk of PTSD after exposure to a traumatic event. So we just look at that in nature. The other thing, during the event, you have to look at the environmental factors. Do with caregiving, who witnessed those type of things during the event. What are you provided with during that event? And then following, it's got to do with the temperament of the individual as well, how they see the world, negative appraisals, how their coping already is. They already had poor coping mechanisms for anxiety or depression or anything in life. They're not going to cope well after a traumatic event, which makes them at risk. And then the environment they're going back into. If they're going into a chaotic environment that doesn't have a lot of social support, recovery becomes problematic for a traumatic event, and PTSD likely develops. And then just in terms, once PTSD does develop, the recovery outlook, you know, you need that supportive environment for anything that you're struggling with. That makes it complicated for anyone with PTSD to improve. All right, I've already kind of hit upon culture and gender. It is correlated with suicide risk, and it's comorbid with substance abuse. Within the VA, we do have a substance abuse PTSD program that's residential, and we have that for a reason. Usually you don't see one independent of the other, usually. I'm not saying everyone. Primarily males tend to be the substance abusers in relation to coping mechanisms. They also, you know, individuals that have a diagnosis of PTSD, they also have a secondary diagnosis of another mental health disorder as well that was either pre-existing prior to the PTSD.
I have a question online. Should I save it?
Yes, unless you think I should answer it now.
We can save it.
Okay. Yeah, I'll let you make that call. So as I muddle through this, military personnel and combat veterans who have been deployed to recent wars in Afghanistan and Iraq, co-occurrence of PTSD and mild TBI is 48%. Okay, so keep that number. I mean, that's a pretty significant number to have a combination of that. And we're going to talk a bit about mild TBI and PTSD later. The next few slides goes through the criterion based on the DSM-5. I'm going to run through this, hopefully not taking too much time, but we'll see. So there's Criterion A, that is when you have been exposed to an actual or threatened death, serious injury, or sexual violence in one or more of the following ways. I think one of the big changes is learning that the traumatic event occurred to a close family member is one of the changes that wasn't present before. But it has to be pretty significant, violent, or accidental to be exposed. Witnessing in person the event, directly experiencing the traumatic event. So intrusive symptoms associated with traumatic event. So recurrent involuntary intrusions, where things pop up and distress. That can include dreams, nightmares, dissociative reactions. So maybe you get triggered and all of a sudden you're somewhere else. And you're physically in the room, but mentally you dissociate and go back to that event. And it affects your functioning. So avoidance of stimuli associated with traumatic events. So, you know, working with individuals at the VA, people avoid talking about this and they go above and beyond and avoiding talking about it to the point where they'll get up and leave the room. If you're asking about distressing memories, if they're not ready, which is okay. And I tell them to tell me that they don't want to go any further. I'm not going to push them. They have to be ready. But it could go so far as that they're not seeking treatment at all, or they're not leaving their home because they're going to avoid crowds, chaos, noise, because they're triggered when they go out in the community. And that can become a barrier in terms of treatment with trauma. So negative alterations in cognition and mood associated with traumatic events. I mean, you're going to have depression, anxiety, things like that present, but you're also going to, they're going to think poorly about themselves. I'm bad because of the things that occurred, the guilt, the shame that may have occurred. And when we're talking about this in terms of veterans, they've made, you know, in their job, they're expected to make decisions for survival and the survival of their team. And that can be a hard decision to make when it comes down to the resulting of someone being killed at their hand. Or if they're witness to explosions or things like that. And, you know, that can be very traumatic. So they may come back and feel guilt and shame over the choice they've had to make and carry that with them. They may think that they don't deserve to be loved. There may be some emotional numbness, inability to feel happiness, a connection, a detachment from others. So, you know, that can be present as well. So, you know, you may have marked alterations in arousal and reactivity, irritability, anger, reckless, self-destructive behavior, hypervigilance, exaggerated startle response, again, problems with concentration, sleep disturbances. So on these, you know, it has to cause impairment. It has to be clinically significant. It's not attributed to other things such as TBI or medical problems. Not that TBI and PTSD cannot co-occur. I don't want to say that. And it has to last for more than 1 month. It can be with dissociative symptoms, and that can be depersonalization, where you're detached from everyone, or derealization, where you're somewhere else. So it's important to kind of note that and specify that. All right, so I kind of got through that a bit, and I'm moving very quickly, watching my time. But in terms of TBI and PTSD, when I started, I talked about it being twofold. And looking at TBI and PTSD twofold as, can severe TBI and PTSD exist together? Absolutely, they can. Research out there previously said no, because people can't remember the event. We're seeing that people can remember emotions. May not remember the details, but the emotions are still there. And then when we talk about what I just really rushed through, the symptoms of PTSD, irritability, poor concentration, problems with sleep, all right? And looking at mild TBI, that's very similar. So I'm going to go back to, because I said we would reference this again, then I'll come back. Oh, there it was. Look at these symptoms of mild TBI. And what are we seeing? Poor concentration, irritability, tired, depression, memory problems, headaches, anxiety, trouble thinking, dizziness, blurry or double vision, sensitivity to bright light. Well, I mean, the top top two for sure, poor concentration, irritability, those are in PTSD as well. Problems with memory can happen in PTSD. So, you know, sometimes, and I think it's it's easier to think about my problems being more medically related than mental health related. So usually we see people and they think that their mild TBI is causing impairments years later. Okay. Catch up, go back. The other thing, and in particular something that Dr. Rudisell was going to talk about, is she was going to present with a case. And so I'm going to summarize that case a bit because I have been able to kind of talk to her about that case briefly. Case of Martin. It's a TBI case. He was driving down Nicholasville Road at a red light. He was hit. He was riding with his girlfriend who was pregnant at the time. It resulted in a severe TBI for him, the death of his girlfriend and unborn child. So, you know, in treatment, we definitely saw some impairments in terms of severe TBI. But what was interesting is he had these other emotional experiences that we had to kind of make sense of in our treatment and how we looked at him. So every time he got in the car with a therapist to go out in the community, he would have an emotional outburst in the car. Anxiety would occur. He didn't know how to respond to it. He couldn't verbalize why he was experiencing that anxiety. And he would have self-abuse behaviors. So the other times that some of the anxiety would start to occur is when someone would talk about children, pregnancy, yet he had no memory of the event. He also would have times where he wanted to avoid discussion of his girlfriend and his unborn child at the time. So that avoidance was there. That marked irritability was there without recollection of the actual event. He hadn't been, no one had exposed him to details of the event. So, you know, you have an individual here that has had a severe TBI and he has these marked changes in emotions, even though he doesn't have memories of it. So that's relevant on how you engage. You know, over time, exposure did happen because one of the treatments is exposure. He would get in the car and he would go with therapist. And, you know, the downside, there ended up being an accident again at the same light. So there was a lot of backstepping. I know. She reminded me of this case this morning when I briefly chatted with her. And so some of the work we had done, we had to kind of start again. So he was re-exposed. So, you know, what does that mean in terms of PTSD and not having a memory of that event, but still having the anxiety and the fear? You know, we developed some fear responses, and that anxiety is one of them. So it still can happen and still can occur. And so studies have shown that people still experience the physiological distress.
amnesia?
He knew about his girlfriend. He knew all that information. But he didn't remember the event. Yeah. Which, in a lot of cases, that is a protective event. That amnesia is that it doesn't develop into that PTSD. That's protection. And so a lot of times I think when we are looking at in treatment, we thought it was such a protective event that you couldn't get PTSD with a severe TBI because you can't remember the event. That's not true, and we're getting more research out there to show that's not true. Now, it's not typical. We'll keep that, but we don't want to say that doesn't happen. And the case of Martin that I just discussed is, and his name's been changed and everything, is a good example that we still had to work on some exposure and some strategies. Now, cognitively, we weren't processing the event, but those behavioral and exposure to the road or a vehicle or topics, over time, he improved. He initially, the self-abuse incidents were really high, and we were able to track those over time because every time those happened, there was an incident report that occurred, and so we could track our interventions over time, and he did improve over time on the amount that he was hitting himself in the head due to that anxiety. He also would hit walls and things like that at times, but that's got to do with some of those emotional behavioral deficits that you're not able to make good coping strategies and decisions. You're impulsive, and that's just what you go to. All right, that kind of leads me into things to consider with impaired memory. So one of those things is fear conditioning. So you get this fear during a traumatic event, and it results in conditioning in which subsequent reminders of the trauma elicit anxiety. And that's the perfect thing I was talking about when he felt that fear when he was on Nicholasville Road, but he didn't remember it as to why, but he still felt it. And so we have to consider that in terms of looking at PTSD and TBI. And then he would be reactive to reminders of the trauma. So just children, pregnancy, things like that. Memory reconstruction. So there are times when you have some impairments in memories. And then we kind of develop our own memories, either from information that we've been told, not due to actual memory of the event. So we reconstruct it and then relive it in our mind. So typically those, when that occurs, that looks like more of just a picture of the event, not a sequence of events. So a person may describe only what they see in that picture. And not, I was driving down Nicholasville Road, this happened, we were hit, this happened. So it's not a sequence. It's just a picture of events. And then you may have some post-amnesia resolution would be what this is called. So say that you're kind of disoriented during your injury, and you still can kind of see bits and pieces of it. And this is more with mild TBI because you're not so impaired at the time. So you start to remember some of the bits and pieces, and that can cause some impact, and that's typically related to mild TBI. So there's some distress there. Again, PTSD risks after TBI, what we know and what research is showing is that people who have had a mild TBI are more at risk for developing PTSD. And that's in nature too. more likely the event itself than the actual mild TBI. But I'll hit up on that in a sec. So like I said, PTSD after more severe TBI is less common, not impossible, whereas we once thought. So, you know, if we look at mild TBI and PTSD, so this is where it gets complicated. And what we see within our clinic is that people come in and they've been asked if they've ever been exposed to any injury, a blast, where, you know, they're flagged for a TBI. They get sent to polytrauma clinic to be assessed. And in that assessment, we look at all those factors that I talked about: loss of consciousness, PTA, and things like that. And they go through and they see speech therapists and they see me, and then we as a team determine the level of impairment for them. Majority of those are mild. So what does that mean? They're still years later having these problems. They're having poor concentration. They can't remember grocery lists. They, they may say, my wife was just telling me something and she said I'm not listening to her. I can't repeat back what she said. It's not that I don't want to, I can't. Why is this happening? It has to be the TBI. What we know is that mild TBI does improve 1 to 2 weeks, up to 3 to 4 months after the injury. What complicates it is those symptoms that overlap with PTSD and the presence of those symptoms. So when there's been a couple studies within military, 2 actually large-scale studies. So there's more impairment in combination of mild TBI and psychological disorders, but this is strongly related to psychological factors after trauma. So that means that when the psychological disorders have been treated, so they go back and they get treated, the mild TBI, the symptoms that they were complaining about in regards to the TBI, poor concentration, attention, non-existent. Okay, so complicating factor is the trauma. It's got to do with the supportive environment. It's got to do a lot with sleep. One of the biggest things that we talk about is sleep with our veterans, because they are not sleeping. Anything less than 6 hours on average, because everybody varies in the amount of sleep that they need. I need about 12 hours. I don't get that. But anyway, we're going to go with average here. Anything less than 6 hours is operating as though you are legally intoxicated, which is impaired, right? And we have soldiers out there serving our country that aren't getting good sleep. And they're doing us a service and serving our country and protecting us, but they're lacking sleep. They've also got really bad sleep patterns when they return, and that's hard to break. And then you throw PTSD on top of that, nightmares, hypervigilance, patrolling their home environment. That doesn't help things. So what I can say right now is that when we see mild TBI, we consider that a concussion, okay? And which improves over time. Psychological factors should be treated, okay? And those impairments should improve once the psychological factors are treated.